endoscopic spine surgery at the lower spine when we have a surgical microscope. Because the surgical microscope is very common. It will be called now the golden standard. And everybody is trained on doing this. And the endoscope is quite different. I'm growing up in East Germany, so I learned a lot about philosophy and I learned about dialectic. That means when we're getting a huge amount of things, and we're getting a huge amount of this surgery, yeah? That means we get a big quantity. There will be the next step in kind of revolution to make a new quality. And though I think the endoscopic surgery is a new quality, and the question is the surgical discectomy, the laminectomy, the golden standard, must be endowed. If you look back in the history, especially of neuroendoscopy, endoscopes are very old. Cossini first used an optical system for visualization of internal organs in 1807. It looked like this. But even in 1879, Max Nietzsche designs the first modern endoscope. And you see, these endoscopes look very similar to the scopes we are using today. And even there was a desire to achieve best visualization for medical treatment. Later, there was a vogue in neuroendoscopy. It started in 1910, especially in the time of 1920s. There had been a lot of use of intracranial endoscopes, and even William Mixter, who is the father of the discectomy, was one of the pioneers in neuroendoscopy. In 1924, he used the endoscope for intracranial surgeries. But at this time, the endoscopes and especially the instruments hasn't been well developed, so they went on a couple of problems and it stopped. Now we have a rediscovery of neuroendoscopy, and you see here, now we can do a lot of surgery, especially in the cranial region, as skull bars endoscopy. Now we have developments in vascular cranial surgery, though the endoscope in neurosurgery is really coming back. On the other hand, there had been an early development in spinal endoscopy. It started in 1931. It was more like an epiduroscopy, but people like Hausmann Forst as well as Schreiber and Hughes had been the first using endoscopes. I'm happy I was 91 together with Hans-Jörg Loy. So I did my first endoscopic procedure at this time with him together. At this time we didn't have any working channel scopes. We worked with knee arthroscopes, used the bipolar approach, and started to do our first things. Barbex Camping created the first working channel endoscope and developed the anatomic basics for endoscopic disc surgery. You see here, that's Barbex Camping doing his surgery. This was his first scope. And this was the first step we got in the market to doing working channel-based endoscopic disc surgery. Why did we need it? We heard about this. We got new devices, we got new techniques, and though it's becoming more and more real to do endoscopic surgery, yeah, the big question is, give the microscope enough benefit? You know, we can have a 3D picture by microscope, but it's not necessary, because when you use an instrument, you get your third dimension. So even by a two-plane optical system, you can work in third dimension. On the other hand, you have good lighting. I think an endoscope is giving you a better lighting. But you have a stabilized operation area. I told you I went in problems to using magnifying glasses, but I'm always moving my head, and so it was difficult. Yeah? And microscope is really stabilized. An endoscope is moving too. And though it happens when you start it, yeah, and you don't fix it in the beginning, you have problems to get your orientation. That's the reason the best is when you do this, to fix your optic on the disc and to work really proper. Because when you move it too much, you will lose orientation. This is the other slide about the history about this surgery. You know, Mixter published 34 his paper about discectomies. This led to an extension of discectomies, so he was called the father of the discectomies. But in 1952, this had been the latest paper of William Mixter. He went it out. He described all the pitfalls he went in, And he said the dorsal interlaminar approach, it's a technique for discectomy, cannot be the final solution for treatment of the herniation. In this paper, he said it will take 10 years to solve all these problems. We are now more than 50 years later, and we haven't solved all problems of the spine yet. But this led to a lot of new developments, especially in the posterolateral approach. This started in '64, and a new placement of different steps in this surgery because there is a gap between failed conservative treatment and open surgery. And if a patient fails conservative care and this or her condition does not warrant a discectomy, arminectomy, or fusion, the patient is normally left without effective treatment options. And we know open surgery has problems. So here we have the studies from Sweden that register every patient will be under control, and there's a reoperation rate of 5% after 1 year and 10% after 10 years. Similar situation in Finland. They control every surgery, and at all there's a reoperation rate of 14%. So the first surgery, laminectomy, didn't solve everything. And at the end, if you look to the States, there we have the main lumbar spine study, that's field research, randomized controlled by the health insurance. They figured out that all 90.2 of the patients they underwent the first discectomy need a second one, and only 63% of the surgical patients were really subjectively satisfied. So the golden standard of microscopic discectomy cannot solve all problems. The advances, I explained it, minimal surgery. What means approach trauma? You see here, that's a picture of a microsurgical decompression. You see the huge damage you made in the muscles, especially you disrupted all the multifidi, the most important muscle of the spinal segment, and this leads to other problems besides the sciatica and the irritation of the nerve root. So I told you, I prefer to say minimal aggressive, don't harm the structures on the way to the pathology. The requirements I have shown in the anatomic lecture. Yeah? So we go back to microsurgery. Is it the golden standard? It's really most common for neurosurgeons. We have standardized and educated techniques. I think it's part of the residency of your curriculum. You will be trained 6-7 years in doing this kind of surgery. Yeah? You have a 3D visualization, and never forget, in most neurosurgical ORs, a microscope is available. You don't need any new instruments. But it's only the approach. If you use an open approach, for example here on the cervical spine, that gives you a better overview, it's easy to bring implants in, you can do a radical complete discectomy, but at the end there will be more destruction of tissue. If you do a minimal invasive approach for the endoscopic, for example, yeah, the endoscopic approach requires the knowledge of the anatomy to go directly to the pathological region of the disc that's damaged. Now we can do fusions on the cervical lumbar spine as well. We do only a selective removal of disc material. And never forget, the patients are more and more demanding and requiring these kinds of surgery. So the big question, we all have to be big surgeons and do big cuts. I think the way of view can solve the problems, and the lightening, the look there, it's the biggest issue. There's no darkness, there's sometimes only an absence of light. Yeah? So you have to get a good view, you solve this. This is important to see how you do enlighten things, and you not only do a straight enlightening, you can do with an endoscope wide enlightening. And when you look here, the endoscope gives you a view behind the edge, because we have angulated endoscopes. You see it here. You have this angulation of this curve, but even when you do it like you do it in arthroscopy, you can turn your endoscope, you can widen your visualization field, and you can get all a bit of field. And so you have a huge overview with the endoscope even behind the edges, and you can see this here. That's I have the pictures for the endless modulation. You see here what I'm doing. I'm doing like, it doesn't look really like this, but I look with the endoscope behind the edge at the whole inner annulus. You see here, that's the same movement. This is a technique for endless modulation we are using for distance too. And so you can see how you can endoscopic techniques are requiring an integral transfer of the single pictures like a mosaic to a whole picture. That means you have a lot of small pictures at the end. It's giving you a whole picture. I don't know what we do this minute. Maybe I have to show it later to you. Yeah? Then we got development of technical devices. It's like the TV sets. We started in the 30s with SIS TV sets from Ardennes, but today we are talking about HDTV. The same happens in the OR, and though we have the newest ORs, this is the technique by Storz, you have really high technology ORs, you have this OR1 system, that means you have high definition cameras, you have special screen, you have special technology, especially the ITA system. Yeah? You can use new xenon light sources. The next step will be LED you're getting for this. You have this documentation system, AITA. It's really very recommended. It's one of the best in the market at the moment. You have these special pumps you can use, and you have special design apparatus for bursts like this. It's a motor system for the high-speed bursts. The approaches I have explained to you, that you go from lateral to this, you can approach 60% of the disc. You have no bleeding unless at your scar. I don't know why the video doesn't work. This is the beginning, how we worked in 91. This is a bipolar approach. That means we use first on one side the endoscope, from the other side we use the instruments. Then we improved it by using working channel scopes. On the other hand, we simplified the whole technique with physical fix. I will explain it later. That's a very simple technique for beginner, for an inside-out technique, using especially the stereo radio frequency. And you can get pictures as well by the small, tiny endoscope to control what you have done. And we are using more and more the extra distal techniques for the working channel scopes, as I explained it here. Here the safe zone again, where you have to go. I showed you. Sometimes you have problems with the crest, so you have removed bone to go in. You are using these different instruments, and here you can see how we are doing it. You see we are using the special kerosene to remove the lateral facet parts of the SCP to go into the spinal channel. Very important is to stop every bleeding, to avoid any red out by the endoscope, because otherwise you lose your view. Here we are using the special diamond high-speed burr to remove the bone, and we are really opening this foramen to go inside. And when we have done a proper preparation of the disc material, it's very easy to remove this huge sequester or this restricted material and to go inside, because when the sequester is inside of the spinal channel, you cannot go to the neurostructures because the neurostructures are pushed away. But when you have removed like this huge piece, you see now you have the full deliberated nerve root, you can check it, and you have full decompressed neural structure. And this is what we want to do, and you have only been done a small damage by your approach. The other technique is, I told you, I go as far lateral as possible to use a far lateral approach for this. Especially we are using it when you have medially located sequestrated material. If the material is behind the transversing nerve root, and you have seen this picture too, you see that's the situation. Here you see the nerve root, the sequester is behind the nerve root. That means by the instruments you have to elevate the neural structures, go under the nerve. That's sometimes a little tricky to catch this huge piece is lying there. We don't for this the disc, we don't destroy the disc, we don't make a hole in the disc, but we can catch at the end this huge piece, and you see how you can remove it. Dr. Gunn visited me, he saw at the end we called, or we called it outside technique, to work only in this spinal channel without opening of any disc. The interlaminar approach is getting more and more popular. The reason is a lot of spine surgeons are very common with the view, with the technique. That means we are going straight less aggressive it is in relation to the epidural membrane. Yeah. Though at the end I want to show another issue I love to do with the endoscope are facet twists. You're seeing it very often. Yeah. You have really mineralization of the approach trauma by the endoscopic sheath. I use the meter sheath for this. You will preserve all the dorsal muscular ligamentous attachment. Stability, very important. There's a big discussion about the treatment of these twists. Do we need infusion or not infusion? I think fusion is less step. We do less cognitive destruction. You have no intraoperative blood loss, and you have a really fast surgery. You see here a nice case I have done. This is this huge cyst there, L5S1, and we use the endoscope like this to remove this cyst. You can see here how we are doing it. We are using this kerosene to open and remove a little bit of the phlebum, to do a phlebum decompression. Here you see the facet cyst, you see the neurostructures. You have to do really a proper, careful preparation because there are always a lot of adhesion between this cyst and these neurostructures. You see here it's a ganglion cyst, it's coming out. When you have done this, you can turn the sheath. The cyst is going inside of the sheath. Then you use different instruments to remove this cyst. You see here we partially removed the cyst. You see the quality of the cyst, but at the end we are removing the whole material. Now we can check the whole epidural space. Its neurostructures are absolutely free. And here you see the picture before and after this surgery, and you see we totally remove this ganglion facet cyst. What are the outcomes? I have shown on Saturday this special lecture about the evidence, but we know we have an evidence for this surgery. We know that the endoscopic procedures are equal to open surgeries. Sometimes we are showing we have less complications. There is an evidence that we have economic benefits, especially in relation to the return to work. Though the endoscopic surgery has a place. Here another review that the current data suggests that microsurgical and endoscopic techniques are superior to the classic technique for the treatment of single level lumbar disc herniation with respect to the volume of blood loss, systemic repercussion, and duration of hospital stays. And all three surgical techniques were found to be effective for the treatment of single level lumbar disc herniation patients without degenerative vertebral deformities. That's a review of all randomized clinical trials. The funny thing is, here, especially in the UK, everybody's referring to Cochrane. First, I did any research about Cochrane. Nobody knows who founded Cochrane. Everybody in Cochrane is scared to lose money. I approached Gibson directly. Then they did really selected research. You know, the first Cochrane release was 2005. After we attacked Gibson, he had to do another release in 2007. You can read it especially in relation to the laser. It will be funnier, then there are 3 more randomized controlled studies. He left out 2005. And since 2007, there was no review anymore. So I think Cochrane was a good idea, but Cochrane followed special interests. So even evidence-based medicine have a strong bias. So we can assume the advantages of the endoscopy is really minimal aggressive approach with less complications. Reduce pain possibility that sometimes carry. I thought you have to calm down the patient. The patient doesn't take the surgery serious. You have a short rehabilitation, a fast return to work. You can do it without general anesthesia, and you have like a neuromonitoring cause of the local anesthesia. You have a direct approach to the pathology, and you have less or no bleeding. But never forget, it's really a technical, ambitious procedure. It takes time to learn it. After the beginning, you need sometimes high radiation. You have long-lasting operations. There are some nice papers about the shallow nerve input in relation to the radiation you are using. When you are not sure, you do more radiation. When you are very common with this procedure, you can reduce your dose. That means you have a steep learning curve, and there's a need for special instruments and equipment. You have to purchase it efficiently. What will be the future or the new development? I talked about the high-speed bursts. We have different kinds of new high-speed bursts, so we can do really good bony decompression, especially by the diamond bursts. On the other hand, we are looking how we can solve problems. You see here, I did by this post-lipectomy syndrome with a lot of scar, this damage of the dura. This was a dura leak. And you see how you can seal this damage of the dura through the endoscope with special frequent-use patches, so you can close this whole leakage to avoid any problem by this dura damage. Then we discussed about complications. You can get scar tissue. Here you see a picture of the scarring of the foramen, especially after bony decompression. It happens, but it happens very, very rare. Then very important is the big question about implants. We have a further improvement of the instruments to do this. We can do at the moment bony fusion in the vertebra. We have special designed implants to do a full percutaneous 360-degree fusion. And we are working on biologic nucleus replacements. Here you see the former way we had it done. We started with B-twin, then we did this percutaneous screw placement by the small incisions and we placed this bone down inside. But the latest step is this new device. There's an expandable cage. You can see we place it through the endoscope, then we expand it, we get this traction, and you see how well this endoscopic assisted cage is really placed in the vertebral space. Here we are using facet screws to simplify. We can do this whole fusion with 2 1-centimeter incisions. Though we can conclude, the endoscopic techniques are an alternative to the microscopic surgery. It's not a full replacement. You need still open surgery. And never make the failure we learned in general surgery. Today, a doctor is able to do laparoscopic gallbladder removal. But a lot of doctors are no more able to do it in open surgery. So besides the endoscopic techniques, you must be skilled in the open techniques. The same situation we have on the cervical spine. Cervical endoscopy is dangerous. You must be able to open a cervical neck. Because when you have a carotid injury, you have to stop bleeding. Otherwise, you will go in a lot of trouble. And I know cases in the world, there have been all 6 cases of death after cervical endoscopy that had been surgeons, they are not being able to control the bleeding caused by the endoscope. Because they never had learned to use a knife on the neck. Then, the endoscopy of the spine requires, besides the skill, the exact knowledge of microanatomy. You have to know what you're doing. The microfiling of the anatomical structures in the field, operation field, is the knowledge of what helps you to avoid complications and give you a good outcome. And you have to know